Thank you for joining us for the Johns Hopkins Government and Community Affairs Showcase Series, which highlights different Johns Hopkins programs that have a strong relationship with the state of Maryland. My name is Pam Beidle. I'm the state senator representing District 32 in Anne Arundel County. I will moderate today's discussion. Today, we'll talk with Ed Kumian, CEO of Priority Partners. There are 9 managed care organizations in Maryland referred to as MCOs. Priority Partners is the largest of these organizations. Priority Partners is jointly owned by Johns Hopkins Healthcare and Maryland Community Health System, which consists of 7 federally qualified health centers. It also has the distinction of being the only MCO with all staff and operations based in Maryland. Mr. Kumian has been with Priority Partners for over 15 years. During this tenure, Mr. Kumian has led the organization through a strategic planning process and helped create the Maryland Managed Care Organization Association, known as MMCOA. We will learn about the important role MCOs play in the care for Medicaid patients overall and the unique services Priority Partners is able to provide. And Mr. Kumian will discuss the crucial role MCOs have played with the end of the public health emergency and the need for thousands of Medicare recipients to redetermine their eligibility. Before we get into the discussion, I want to go over some logistics. This webinar will be recorded and will be posted to the Hopkins at Home websites with captions included. Additionally, the questions and answers function has been enabled during this webinar. Please feel free to type questions there. We will do our best to respond to as many questions as we can in the time that is available. With that, I'd like to have Mr. Kumian start with providing us an overview of Priority Partners.
Thank you, Senator Beidle. Prepared a handful of slides for you just to give you a background on Medicaid and talk about some facts and figures, background of Priority Partners, some issues we're dealing with as MCOs, and of course, redetermination, something that's on everyone's mind right now. Next slide, please. So it all started back in 1997 with the Balanced Budget Act, where CMS was looking for more accountability, cost controls, and better outcomes. And they wanted more members in managed care. Used to be fee-for-service, much like we have Medicare fee-for-service, and they wanted to shift as much membership into Medicaid managed care plans, much like Medicare Advantage is today. So it's been very successful over the years. We're now have 40 out of the 50 states have Medicaid managed care programs where most, if not all, the membership is in a Medicaid MCO and providing all the benefits to the members who sign up for Medicaid. If you, in order to qualify for Medicaid, originally you had to have income no greater than 40% of the federal poverty level. The program was relatively small back then. It's expanded a couple times, once in our state in 2009 to 113% of the federal poverty level. Of course, with the ACA, it went all the way up to 138% of federal poverty level. 2014, just to put that in perspective, you have to make under $19,000 as an individual to qualify for Medicaid per year, and no more than $40,000 for a family of 4 to qualify for Medicaid. Some of the things that it doesn't cover is anybody over 65 and long-term care. Each state has different programs, and you've seen one Medicaid program, you've seen one Medicaid program. Our state, for instance, doesn't include behavioral health in the managed care program. It's carved out to Optum, and It does not cover adult dental and vision, actually both dental. Recently in the legislature, they this past year, they approved adult dental for Medicaid, and it covers everything restorative and preventative care. So we are one of the few states that provides that level of benefit, a much needed benefit. MCOs were previously covering that out of pocket, that it being covered. Another key point is there's no out of pocket expenses to members. Everything's completely covered by the MCOs. And we are the payer of last resort. We're constantly coordinating benefits with other insurance companies. About 5% of our members have other coverage, whether it's Medicare or commercial insurance. I'll give you a few other fun facts and figures. Some of it might surprise you. One of the interesting facts is 20% of our population, both nationally and in the state of Maryland, is covered by Medicaid. So a significant portion of our membership. Another interesting fact is a lot of pregnant women on Medicaid, and 40% of the births nationally and in the state of Maryland are covered through Medicaid, a very high figure. And every Medicaid program has to have a very strong maternal child health program as a result of the high birth rate in our population. With the expansions that I mentioned here, our uninsured rate is down to 6.5%. It used to be in excess of 13%. So we're really doing great as a country, making sure that everybody at least has some form of healthcare coverage. Next slide, please. One of the other facts is who pays for this. 50% of the cost of the program is paid by the federal government, CMS, and 50% is covered by the state taxes. Some of the numbers by that you see here, that almost 50% of the population is under age 21, so relatively young population. And you can see, as Senator Beidle mentioned, we have 9 MCOs in the program. Priority Partners is the biggest MCO with 366,000 members. We have 23% market share. We're followed closely by AmeriGroup, or they call themselves WellPoint now, at 340,000 members. We have a statewide footprint. We're in every county of the state. You can see where those members reside. They're primarily in the large metropolitan areas, Baltimore City, the DC suburbs, that's PG and Montgomery County, and Central Maryland, which includes counties such as Baltimore County and Anne Arundel County. We have the dominant share on the Eastern Shore. Roughly 85% of the membership on the Eastern Shore belongs to Priority Partners. And of course, we have a strong footprint in East Baltimore with our owners, Johns Hopkins, leading the way there. You can see how much Medicaid's grown over the years. We started off with under 500,000 members in the program when it started, and we're up to about 1.6 million members today. And the ACA expansion was a big piece of it. We grew about 200,000 members as a result of the ACA expansion in 2014. And we're at an all-time high right now because of the PHE. Starting in 2000, CMS suspended redetermination. There were no people kicked off of Medicaid for roughly 3 years. And over that time, our program grew by 300,000 members as a result. The PHE was just recently ended, and now that redetermination process has restarted. And we are going through those 300,000 members, and over a 12-month time period, redetermining whether they're still eligible or not. It's anticipated we'll lose a significant number of those people as they have now have jobs or don't qualify for other reasons. So we're thinking somewhere between 5 and 10% of that total 1.7 million members might roll off the books in the next 12 months. Next slide, please. So what makes us unique? We're one of 9 MCOs, but I think what differentiates us is our owners, Hopkins, and our FQHC owners, 7 of them, 2 on the Eastern Shore, 2 in Baltimore City. A third of our membership is attached to our owner providers, and it's our collaboration with our owners in delivering care and meeting the needs of our members that I think make us unique from folks like WellPoint and United, who are just insurance companies. And our mission is really what sets us apart as well, in that we're dedicated to the utmost quality and access for care for our members. Profit is important in order to stay in business, but is not the major reason why we're in the Medicaid population. It's to serve the community and help our providers. As I mentioned, we're also, as a provider organization, very provider friendly, as opposed to some of the other MCOs who are focusing on profits first as being stock held companies, and quality first and quality second. We always put the quality first and then try to make a profit secondarily. Next slide, please. So what's in our future? Talk everywhere is on redetermination right now. I was just at a conference where we had somebody from CMS come to speak about redetermination, and there's a little bit of panic at CMS with about 1 million people nationally falling off the rolls when we restarted redetermination, and as a result, they're giving MCOs more ability to help the members get back on the rolls. Before, we were not allowed to help the member actually re-enroll, just tell them it's their time to redetermine. Now we're given navigator capabilities. We're able to sit down with the member and go to the benefit exchange website and actually help the member put in their information or show them how to do it and lead them through the process of redetermination. The goal both of CMS and the governor here in Maryland is to minimize the impact of redetermination and keep as many people on the Medicaid rolls as possible. So we've been partnering with CMS and MDH to do so. More on that in another slide, but the other thing that we're focusing in is value-based contracting. We're not the deliverers of care, we're more enablers. So we are working with our owner providers on value-based contracts where we're giving them some enablement money to hire staff and resources centered around delivering better outcomes from a HEDIS or preventative care standpoint, and better outcomes, particularly on diabetes and maternal child health. If they achieve those results and are able to also bring down the cost of the overall healthcare, we're going to give them some of additional monies or savings or incentives that we receive from the state for doing so. The other thing that we're working on is MD-PCP for Medicaid. CMS wants to see all payer version of MD-PCP, so we're working with the state on expanding MD-PCP for Medicaid. We're looking to do that in 2024. So mentioned, lots of focus in on maternal child health and diabetes. We could use some help on that. On the diabetes section, it is a nationwide pandemic, so to speak, and looking for new innovative ways to partner with the provider community and MDH on addressing those needs. And social determinants and health equity, a lot of our members wind up on Medicaid because they lack housing or education, access to food. Their health care isn't their primary concern. And one of the great things about the Medicaid program is we're given money, but we can use it in different ways to achieve the outcomes that MDH wants us to hit in terms of delivery of care. And that may be using some of the money to help address food insecurity or housing needs, which then puts the member in a better spot, start addressing their healthcare needs. And health equity, that's a big deal in our industry as well, and making sure that whatever the needs of the specific populations are being met, and they vary. Disabled members need different levels of care versus pregnant women, versus people with behavioral health needs, and making sure that the resources are allocated appropriately by those populations and geographically. We have huge issues with access in rural areas, and we're trying to spread those healthcare dollars in the right areas so that everybody's getting fair access and treatment in healthcare. And finally, primary care access. Primary care access is a huge problem here in Maryland. I think there's more demand than there is supply, and how can we get the most out of our network and meet the needs of our members. This is particularly an issue in rural areas on the Eastern Shore and Southern Maryland and Western Maryland. Telemedicine has helped a lot, but we need to recruit more doctors and find more innovative ways to address the needs of primary care in this state and nationally, quite frankly. Next slide. Partnership on redetermination. So this is not our first rodeo on redetermination. We went through this issue back in 2015, shortly after the ACA expansion. We had an issue with a failed exchange portal where members couldn't redetermine back then, and we lost hundreds of thousands of people. Didn't have navigators in place to get people re-enrolled. This caused us to band together as MCOs and form an association to deal with operational issues just like redetermination. We've led the way, I think, on redetermination here in this state, and we're far ahead of what other states are doing on redetermination. We banded together and contributed $2 million of funds across the 9 MCOs to create a communication plan through GKV. This is a local marketing plan who did the GoVax campaign to get members aware that they're going to have to start redetermination once the PHE ended. A lot of work, you've probably seen it, radio, TV, outdoor media, digital media, social media. It's everywhere, and it's done in a simple way with things like QR codes, where you can just use your phone and it will take you right to the exchange web portal where you can redetermine, and it's got phone numbers where you can access navigators if you're having problems getting through the exchange portal. We led the way here, and MDH jumped on. They threw another $1 million on top of our $2 million. So $3 million going towards communication plan that will happen over the course of the 12 months redetermination, where we get through that roughly 300,000 membership that went unredetermined over the course of the past 3 years. We've been doing a lot as health plans as well. We are doing texting, emailing, IVR calls. Those are kind of like robocalls, and a lot of direct mail as well. Of course, lots of data and reporting and tracking. We want to know where the bottlenecks are and the breakdowns and what's working and what's not working, making sure we're diverting resources in the right way and pivoting as quickly as possible, minimizing the redetermination issues. I mentioned the additional expanded authority to MCOs for redetermination. They also came up with some interesting and innovative ideas in terms of using additional information to help members redetermine, including using SNAP benefits and other forms of information beyond just tax filings to verify income. And I think that's going to have a huge impact in limiting the amount of people that fall off. And there are people that are in various stages of doing their paperwork to redetermine, and CMS is giving the states a little more latitude to delay kicking people off for incomplete applications and giving members more time to do the redetermination. We're also working very closely with our provider community, sharing information through the MDH website. We have a provider toolkit with videos and information for both the member and provider when they run across issues with redetermination and how to get it done. I could talk for hours on Medicaid. I've been through this health choice program since the start. I helped set it up for Priority Partners as a consultant back in 1997 before joining Hopkins in 2002 and eventually becoming the CEO of Priority Partners. So I've seen it all, the growth, the operational issues, the expansion, and all the change. And there's one thing that's consistent with Medicaid is there's always lots of change and innovation happening year over year. It's what keeps it interesting. And MCOs need to be very nimble and agile and be able to pivot quickly on issues that come up like redetermination.
So Ed, thank you for your presentation and for all the work you've been doing for our Maryland residents. Just, I guess, one overall question what's been the program's impact in Maryland?
I think one lower cost. We provide a lot of oversight and management from a plan perspective, making sure care is delivered at the right time and at the right place and the right type of care, as well as coordinating care with other payers, making sure we're the payer of last resort. And we have very extensive fraud, waste, and abuse programs to limit overall cost as well. And making sure that both members and providers and the health plan are all jointly accountable for the tax dollars that are spent for Medicaid. Of course, first and foremost, I think one of the best things about the program has been the quality. The quality has increased substantially. There's incentives and penalties for MCOs for the delivery of overall health care. So we are being incented to work with the provider, making sure people are getting their prenatal and postpartum care. Their A1C levels are in range. They're getting their breast cancer screening and cancer screening done, and just basic overall care. And we're also making sure that we have the POP health outcomes on maternal child health, limiting the number of bad outcomes, low birth weight babies, and also on diabetes, making sure, as I mentioned, the A1C levels are in control, and doing lots of screening. The innovation, I think we've done a lot of innovation with the state, putting in programs around POP health and our ability to move more quickly as well.
And tell us about your future plans and goals for Priority Partners.
Some of the future plans, I think, in talking with the new health secretary, Dr. Laura Herrera Scott, are potential some carve-ins. I mentioned at the beginning of the program that behavioral health is carved out. That is something that we're looking at. Integrated care is really important. 40%, if not more, of the Medicaid members have some type of behavioral health care issue, whether it's mental health or substance abuse or both. And it's hard to take care of the members' health issues if we don't know what their behavioral health needs are and whether they're being met or not. Because of HIPAA, we're not allowed to have that information unless the member wants us to have that information. So we're kind of flying blind there, and it'll be much easier if we have some more insights and control on making sure members who have behavioral health needs are getting into care, so that we can also address their medical needs as well. Also looking at the duals, I think that's an opportunity to carve in as well. And looking at the social determinants and health equity, I think some other states are ahead of the game on that. We're looking to states like California, who have provided additional funding to help MCOs address some of the social determinants and health equity issues. And I know Dr. Laura Herrera Scott's looking into those as well.
And can you tell us what state policies and resources have really made this program so successful?
I think the incentive programs, they really help align us, the health plans, with the providers and the members to deliver quality health care. Telemedicine. I don't know where we would have been during the pandemic without telemedicine. So much of the care was delivered through telemedicine during the pandemic, and we continue to be able to use telemedicine going forward. As I mentioned, primary care access has been a problem, and this is one way to address lack of primary care is telemedicine. And finally, the funding of adult dental. Adult dental has not been covered as a benefit across all Medicaid plans across the country. And I think our state made a wise decision to cover adult dental. Dental issues lead to other medical issues, and if untreated, cause unnecessary outcomes, bad health outcomes, and higher costs. So that was something that I was glad to see happen in the legislature this past year.
We were very pleased to see that happen too. And my last question is, tell us going forward what resources or state policies you think would be helpful for priority partners and the other MCOs.
I think more funding around behavioral health, especially, and access especially for mental health. That's a problem that we're seeing across the country and in the state of Maryland. There's nowhere for members to go for mental health, particularly children. I think the pandemic and social isolation has had a huge negative effect on children, and they're having difficulty accessing those services. So working together with MPH and trying to figure that out is going to be important. Also funding, as I mentioned before, social determinant issues, housing, food, transportation, and also with health equity, making sure everybody has an equal opportunity at receiving quality health care and leading the best lives that they can.
Thank you. And that was one of the first questions that came in, asking what benefits should Maryland Medicaid cover that they're not covering. So we talked about mental health, particularly, and I guess the value-based healthcare issues, that the social determinants and other services that folks need. So I think you've answered that question. We do have another question from our audience. If 40% of births are covered and 46% of those enrolled are under 21, that must mean there are a lot of children enrolled in the program. Would extending benefits like the Biden Child Tax Credit have a great impact on Medicaid?
Without a question. I think that would be a great help for the Medicaid program.
And then we have a question about the growing skepticism about medicine vaccines will have. Is that going to have an impact on Medicare enrollment, do you think?
There has been a lot of skepticism with the vaccines, particularly in the Medicaid program. Lots of conspiracy theories about vaccines. Most of the unvaccinated members in the state actually are from Medicaid. I'd say 50% of the unvaccinated population are on Medicaid. They're not very trusting sometimes, particularly of MCOs. We've tried to get the message out through the provider community, but they're also skeptical there. I think there's been a lot of bad experiences over the years in terms of trust with Medicaid members.
A question from Michael: does Medicaid coverage include transgender related or?
Yes, that is a covered benefit under Medicaid, and there are Medicaid does cover, well, at least in this state. It doesn't every state, it varies, but sex change operations are covered, and care for transgender population is completely covered.
And I have a question about the redetermination, because those questions will be coming to our offices as we service our constituents. Has this process already started with redetermination, or is it at some date in the future?
It started June 1st, was the first cohort of members that lost coverage due to redetermination. Roughly about 20,000 people fell off the rolls in June. Roughly 5,000 of those for priority partners. And as they fall off the rolls, the MCOs continue to chase after the members, trying to get them to do the necessary paperwork to get back on to health choice. We continue to make phone calls and send texts and emails, and send people out into the community and work with local organizations like churches and other civic organizations that cater to the Medicaid population.
That's really great. And you know, I know that it's just hard to reach people. So I really am pleased that you're reaching out and that you're able to, you know, provide the navigators, which, as you said, you couldn't do previously. So that's great. I don't see any further questions. Ed, is there anything you want to add as we finish the webinar?
No, I think that's it. Thank you, Senator Beidle and Hopkins at home for hosting us, and enjoyed speaking with you about Medicaid and priority partners.
Well, thank you, Ed. And I really learned a lot with your presentation. So thank you for taking your time this afternoon to explain this important and relatively complicated piece of the healthcare system. I know the important role Medicaid plays to the overall health of Maryland, and your partnership is important to the citizens of Maryland. I'd also like to thank those who tuned in to listen to the conversation in the Showcase series. Johns Hopkins Government and Community Affairs team will host more of these events in the future, highlighting the anchor institution's relationship to Maryland. And for questions, please email them to gca@jhu.edu. So thank you, everyone, for participating today, and particularly thank you, Mr. Kumian, for your great presentation.
Thank you.